Hello, my name is Reed Tuckson, and I am the co-founder of the Black Coalition Against COVID and formerly Executive Vice President and Chief of Medical Affairs for United Health Group. And I am happy to have this opportunity to share some private payer perspectives on promoting health equity in cancer care. Let's make sure we understand health plans have an obvious and crucial role in providing access to quality, cost-effective, and patient-centric cancer prevention, early diagnostic, and evidence-based clinical care. They seek to be facilitators that make interventions better and more affordable across the patient's journey, from the etiology to advanced stages of clinical intervention. We also must remember that the plans have very limited pools of dollars over which they must be responsible stewards within the context of a complex landscape of rapidly evolving basic science and translational innovation, unsustainable cancer cost escalation, challenging patient expectations and concerns, and a rapidly evolving delivery system. And now to all of this, we have the ethics of equity. Here are a few concerns that I think are important that health plans will focus on going forward in the cancer journey. Number one, and most important, and goes throughout all of the elements I will describe, are trust and distrust. The experience of Tuskegee is still rampant throughout our clinical care enterprise. I was health commissioner in DC during the height of the AIDS epidemic in the 1980s. The number one risk factor was Tuskegee. Now, 40 years later, as we fight the COVID pandemic, the number one risk factor for this pandemic in the Black community continues to be Tuskegee. In 40 years, we have done nothing to take this issue off the table. Shame on all of us. And it means then that we will be struck by continuing challenges that will permeate all of clinical care delivery as we go forward. Number two, prevention. Cancer death rates are approximately 20% higher among residents of the poorest U.S. counties compared to the most affluent counties. The largest gaps are preventable cancers such as lung, cervical, colorectal, and liver. This means that if we're going to involve this, screening must be supported by a robust community-level engagement. Plans and providers will need to be very connected to the community-based infrastructure, faith, social organizations, and so forth. This is extremely important to work together. Number three, there is an inevitable acceleration of the movement towards consumerism in medicine and in insurance design. As we move further into the patient-centric care and facilitating more care engagement directly with consumer and patients, plans and their clinical partners must not only confront distrust that has been building over multiple generations, but the underinvestment in science education in our schools. Cancer care at its heart is genetic medicine. People are being asked to make complex, probabilistic, statistical calculations as they work within the context of the patient clinician decision-making process. Messenger RNA vaccines were and are a hard sell in this epidemic. Far too many people simply don't have the requisite science literacy background to participate as meaningfully as modern cancer medicine will require. Worse is the paucity of certified genetic counselors to help people who are really in need of engagement and counseling. Hereditary genetic testing results are going to be very important to going forward, but we've got to maintain the trust to get people to want to participate. And plans will be very concerned about navigating their responsibility to their patients across the spectrum of access, quality, and affordability as a result. Number four, related to these factors are the challenges associated with developing the requisite evidence base for effectiveness and cost value from clinical research. We've got to get past the Tuskegee experience so that we can get people into the clinical research arena. We have challenges ahead, and plans will need to be active in being transparent about the importance of clinical trials and ensuring that it addresses key issues of overall value determination within different demographic populations and reimbursement for the associated medical costs of participating in clinical trials needs to be very transparent. Comparative effectiveness from a total cost of care perspective is a key challenge and must be viewed holistically for the individual and all of the elements that are associated with them sociologically. Plans will also be interested in advancing the science used by the U.S. Preventive Services Task Force to know what evidence-based recommendations need to be made regarding cancer screening services for different populations of Americans and the periodicity of those screenings and the cost value of those recommendations. Number five, data aggregation, integration, and analytics are now core competencies that inform almost all aspects of health plan operations. we must be sure that we are addressing algorithm bias in our artificial intelligence analytic systems. We have already started to see the challenges related to that. Plans will also be interested in how they can help enhance participation in registries that are informed by integrated data sets that include demographic and socio-demographic characteristics, diagnostic staging, clinical notes, and claims data. As value-based reimbursement inexorably moves forward, plans will also hold providers accountable for the quality and cost effectiveness of care outcomes. But they're also going to be looking very much involved with the patient experience with care more in the future. People of color need to know that their experience with care is part of the reimbursement mechanism. And we need to be really, really clear that that is important, and providers held accountable for participating in better patient acceptability care. Number 6, the patient's care journey must be viewed holistically. Plans will continue to travel that road together with the patient and their care provider, but the patient navigators and care managers within the plans need to be partnering even more effectively in coordinating care with the navigators and care managers from the provider community. The social determinants of health capabilities are increasingly being advanced by the plans, and I see this as a very important development as they address the housing, transportation, and food insecurity issues. We know that those are going to be important for modifying risk factors once identified, and so we must look at these things holistically. They will be particularly concerned in addressing the delay from the time of diagnosis to the time that they are seen by the treatment system. And we also have to be prepared to well coordinate addressing the therapeutic relationship of cancer care with other coexistent comorbidities, particularly renal, cardiac, obesity, and diabetes, which will so significantly affect the ability to be able to successfully manage the oncology care. And lastly, the plans will, of course, be involved in affordable access to care and addressing the dramatic cost escalation, the issues of drug pricing from a total value of care. And that total value of care needs to particularly address the challenges for socioeconomically compromised people and their communities. They will also be very involved in identifying the specialty network providers and centers of excellence who prove that they can engage patients successfully in ways that lead to quality and cost-effective healthcare outcomes. This is an exciting time. There's a lot on the agenda to work together on. There are many challenges, but what I also see is many opportunities. But above all, I sincerely hope that the plans and providers will be involved in the fabric of our society to help regain trust and trustworthiness and overcome the tribalism and politicization of healthcare, as much as everything else in our society that will frustrate all of our best efforts. Thanks so much for the opportunity to address you.